Hello, future nurses. We are finishing up Unit 9 with Chapter 24, which is our personality disorders. This is a long and short chapter all at the same time. We do have 10 personality disorders, and we do need to be able to tell all 10 of them apart as well as the cluster that they belong to. So as we talk about these personality disorders, one of the things you'll hear me say is clusters. We group our personality disorders into three, known as A, B, and C. And the disorders within A and the disorders within B and the disorders within C all kind of share some of the same traits. There are a few other different ways you may see these. It talks about A as eccentric, but I've also seen like odd and weird. Cluster B, it talks about as dramatic. I have also seen dramatic, erratic. Ooh, there's one more there, but I can't think of it off the top of my head. I don't know what dramatic, erratic. Anyway, cluster C, we tend to see as anxious, maybe nervous, maybe fearful, as the words that are often used to describe it. Oh, emotional. Cluster B is emotional. Erratic, dramatic, emotional. Cluster A, odd, eccentric, weird. Cluster C, anxious, fearful, nervous, insecure. The words are going to be different, but they all kind of mean the same thing. So what is a personality disorder? Well, they affect about 6% of the population, so it's kind of a decent sized number. We can see it as much as 10% in certain communities. 50% of psych patients. That's a lot of our psych patients. And sometimes what you see is someone will have traits of. If you have traits of cluster A or you have traits of cluster B, you don't quite fit in a singular diagnosis, but you have a lot of the things going on that make up that kind of diagnosis. And I promise it'll make sense. This is definitely one especially in lecture, we're going to look at that TSM. Culture has been shown to have an influence on personality disorders. There's been some good studies in Australia and North America. They reflect higher prevalence rates and differences in just how within a culture it kind of plays that role. They are present in half of all patients with some type of mental disorder, so it is the most common psychiatric disorders. They do occur with mood disorders, eating, anxiety, substance misuse, they amplify that emotional dysregulation. Genetics can influence it. You'll see with some of ours that these patients have first-degree relatives with a different disorder. Certain neurotransmitters, right, influence your temperament. And we do see temperament come into play. Freud is a big one. He hypothesized that personality came from childhood experiences rather than chemistry. So defense mechanisms are definitely seen in these. There's not much research based in it. There's a learning theory that says that children learn these behaviors from their parents, that modeling is not always positive. So the family model can be very important. Childhood neglect and trauma is definitely an established risk factor for personality disorders. The assisted stress model comes in. There is a correlation between trauma, neglect, and other dysfunctional kind of in the family and social patterns, along with the development of personality disorders. I was reading a while ago something, and it talks about borderline, one of our cluster B. And we do see, especially if we have sexual abuse in a female when she's younger, it actually will affect the neurobiology. There are brain changes. And that is specifically higher, those changes in the brain in those females who are later diagnosed with borderline. So we do see a lot of it kind of come into play. So we're going to go through our different clusters. Again, being able to understand the cluster and what we see in each one is extremely important. So cluster A is paranoid, schizoid, and schizotypal. We always ask about treatment. I kind of just say this straight from the get-go with these patients. Meds are not going to fix any of these patients. No way, shape, or form will meds help these patients. They will help with some of the symptoms they are having, but it will not fix the disorder. These patients all need therapy. There is a difference between who will be better with individual therapy versus who will be better with group therapy, but for the most part, therapy is what these patients need. These are long-standing patterns of maladaptive behaviors that come in, so this is kind of just who they are. So when we look at our first personality disorder, paranoid, we just talked about paranoid schizophrenia. The CIA is out to get me. But personality disorders really have to do with how we relate to other people. So paranoid personality disorder is very much going to be someone who is jealous and controlling, social anxiety. They're paranoid within their relationships. They're always going to be hypervigilant, maybe even like hostile, because they always think that their girlfriend's cheating on them. There is going to be zero proof, but they will always think. Um, we do tend to see this more in men than women. We do tend to see these in relatives of individuals who've been diagnosed with schizophrenia. Um, Sometimes we see paranoid personality come in, and then later we get a schizophrenia diagnosis. We do start to see this in childhood. They don't have many friends. Um, they're odd, poor relationships, controlling behaviors. They are not going to forgive, or they'll be using that projection. They're just so uncomfortable. They're going to accuse their partner of being hypercritical when they are the ones who are hypercritical. Treatment, we have to stick to our schedules. We have to be trustful. We can't give them any reason to doubt us. If you're overly friendly, it's going to make them nervous. We have to be neutral. They very much in that psychotherapy versus group therapy is one who needs individual therapy. And honestly, most of our cluster A is going to be that individual therapy versus group therapy. Limit set, straightforward explanations. Short-term antidepressants can be helpful, but again, it's not going to fix anything. The group therapy for them, it can be useful in improving social skills, but they're going to be very threatened in a group environment, which is what makes it hard. Schizoid personality disorder. This is when you're going to mess up. So these are individuals who have a lifelong pattern of social withdrawal. They're not always expressionless. Their emotions aren't always the same. They're seen as odd and eccentric due to just how they interact with other people. In lecture, we're going to talk a lot about movies and TV shows. Some of y'all may not remember. I always think it's a still new movie, but then I remember it's been out for a very long time. The movie The 40-Year-Old Virgin. The main character, Andy, honestly, if I'm going to diagnose him with one, it's going to be schizoid. He lives by himself. He has no relationships. He sits at home all day, like in his la la land. He would rather be with his action figures than with his friends. These are people, they avoid close relationships. They're loners. They may do poor in school. They may be made fun of by other people. Their relationships are majorly affected because they're not having emotional attachment. There is a detachment. They do not seek out. They do not enjoy close relationships. They don't care about approval or rejection. Friendship, dating, sexual experiencings are going to be rare, if any at all. They would much rather have imaginary friends and fantasies. Employment's going to be hard if they need to have social relationships. Like these are your extreme loners. They again may have a family member with schizophrenia. That is very much, we do tend to see abnormalities in dopamine again. We again can't be too nice or friendly. We don't want to try to get them socialized more. They may not want to go to group therapy, though it works, because they're nervous about how the group is going to treat them. They're just very odd when you put them in that like social situation. Like their behaviors are just weird. We can do antidepressants. We can also do antipsychotics. But again, do not focus on meds with these patients because it's going to be based on symptoms. They very much need that psychotherapy to help improve sensitivity to social cues. Now, when we talk about this, y'all always bring up autism, but it's specifically mentioned in the DSM that if our patient has autism, they cannot have a schizoid personality disorder. There is kind of a difference in how we see these symptoms present. Schizotypal is our last of our cluster A. And these individuals, again, they follow the same kind of role, but we see more magical thinking, more odd beliefs, more strange speech, more inappropriate affect. We could see paranoia. We could even see some minor hallucinations. These individuals, again, we see more in those first three relatives with schizophrenia, severe social and interpersonal deficits. They're going to be paranoid about everything. They're going to be anxious. It presents as different though. These are individuals who are more likely to join a cult, join those like strange religious groups. If you're like, who joins Jim Jones and the People's Temple? And I know some of y'all don't know that. You drink the Kool-Aid, you wear the shoes, UFO comes, takes you to this magic universe. It's going to be your schizotypal. Like they're going to believe in everything. I tend to think of that like person who's wearing the aluminum foil, like the foil hat, so like the CIA can't read their brain waves. Unlike schizophrenia, they have these kind of brief periods of delusions and hallucinations, but you can make them aware of these behaviors. And they're a lot less. They're not the same. In schizophrenia, where you can't always call them out on their delusions, these individuals, you can make them aware of that magical thinking, of that suspiciousness. We have to respect their need for social isolation. When I worked in addiction, we had a patient with schizotypal, and it was kind of like the classic. He was very odd. He was so nice, but just so weird. And though in addiction, we really want you to be in group therapy, he was one that we would not make. He did not have to go to group therapy just because of how he behaved. We have to look for suicide. We have to be just mindful. Psychotherapy is great. We always have to look at that cult involvement. Meds are going to be based on whatever's going on. If they're having psychotic symptoms, we give an antipsychotic. If they're anxious, something for anxiety. If they're depression, something with depression. It's going to vary. So our cluster B, erratic, dramatic, emotional. These are some of the patients you're going to see more, and there's some you're going to get really confused on. So we got to pay attention. So histrionic, narcissistic, antisocial, and borderline. So histrionic personality disorder, we think hysteria. They're excitable, they're dramatic, they have to be the center of attention. Drama queens. When I went to nursing school, when we were taught this, it was like the soap opera star. Well, soap operas don't really exist anymore, and now we think about like that influencer, that TikToker. Don't you know who I am? I should be getting free food. They're going to be flamboyant, colorful personalities, super bold. They have to be the center of attention, and that carries over into their relationships. So they don't have meaningful relationships because their partner is going to feel smothered. And honestly, when the relationship ends, they don't have any insight into it. It's all the other person's fault. Especially when they feel threatened, they may have these excessive emotions. They may be provocative. This is when we do tend to see more in females. It's a big circle. Working with these patients is difficult. They don't feel like they need help. If they go to a treatment center, it's going to be for something else. No specific farm treatment unless there is a symptom going on. They're going to need therapy. Group therapy is great. This may be your manipulating group member. You can only share 2 to 3 times today. I appreciate your feedback, but everyone has to share. I know we talked about that before, but this will be that person because they're going to want to turn group about them. If they're being seductive, it is a response to distress. Concrete language, like no euphemisms, straight to the point, keep it professional, assertiveness, look at your feelings. We may see them be overexcitable about like medical things. One classic example is like, oh my gosh, I'm going to bleed to death, like I'm dying. And you're like, no, you have a paper cut. And they're just so overly blowing this up. We have to keep straight to the point with them about it. Narcissistic personality disorder. This is one you're probably going to get right. I know usually when we talk about this in class, and I'm like, who would be a good example of a narcissist? So many of y'all tell me your exes. Entitlement, exaggerated, their own self-importance, no empathy. Their poop doesn't stink. They're the best. But when we psychologically look at them, they're super weak. They have no self-esteem. They're very hypersensitive to criticism, which is why when you do criticize them, they like lash out on you. They need that admiration. Um, I always find the history of the word narcissist super interesting. It goes back to Greek mythology, and Narcissus, depending on which version you read, was a Greek farmer or a Greek soldier, and he was super attractive, and he never gave anyone the time of day, and he was basically cursed to fall in love with something he would never be able to have. And he wound up falling in love with his reflection in a puddle of water, and he stared at his reflection until he died. He could not move. He ignored everything else. He could not do anything but stare at his reflection. Um, This is a hard one to treat because let's face it, less functional impairment. No one's going to admit that they're a narcissist. They can't. Disorders, any personality disorder is not diagnosed till their adulthood, their 18s. But we do start to see these traits in adolescence, and it may be the parents' fault. Again, very Freudian. Parents may give their child this unrealistic sense of talent, of self-importance, which puts their child at higher risk. They can be arrogant. They may have shame of abandonment, depression. They may seek to be validated by other people. I want you to tell me how awesome I am. We have to be neutral. They're not necessarily going to be easy to treat because they're not going to seek out help for their own problems. Individual therapy is helpful in looking at that faulty thinking, but group therapy is going to be helpful because in that sharing with others, they can see their qualities. They can learn empathy. Medication, again, they're not going to seek help because they're not going to confront shortcomings. CBT is always helpful. We may use lithium. We can use antidepressants for their symptoms based on what they're thinking. When we look at that nursing care, don't power struggle. Don't become defensive because it's not going to get through to them. It's almost much easier to just like disengage. If they want something, this is when it is how it is, we are not. No is a complete sentence. Antisocial personality disorder. Don't get confused by this picture. This Willy Wonka is only up here because of the saying. This is Jeffrey Dahmer, I think. I don't do serial killers because I have a fear of serial killers. But when we look at antisocial, this is where you get confused because you think my friend is antisocial because they don't want to go to the party. No. Antisocial is serial killers, like Jeffrey Dahmer. Not Willy Wonka serial killers. I tend to think of antisocial as anti-society's rules. They are deceitful, they're manipulative, and they're doing it all for personal gain. There's no empathy, there's no remorse, there's no guilt. High levels of what we call disinhibited behaviors, which is that risk-taking, disregard for responsibility, impulsivity. Criminal conduct and substance abuse are very common in this population. So Willy Wonka, I honestly put him with schizotypal if I was going to diagnose Willy Wonka. But the phrase, you got hit by a car, I'd feel bad, but I have antisocial personality is more so why this picture is here. Because in antisocial, I don't care that I got hit by a car. Like this again is your serial killers, mob hitmen, all of those. They are deceitful for personal gain. They're going to violate the rights of others. We do hear the term sociopath used a lot. Sociopath does have a different definition, but the definition of sociopath includes a phrase, antisocial traits. So having these traits of antisocial personality disorder is part of being a sociopath. We do see, again, this is an adult diagnosis, but remember, we had something called conduct disorder. And conduct disorder is that pediatric version of it. Criminal misconduct, I'm trying to think if I forgot anything. That lack of empathy, that callousness is that big one. Disregard for the rules. They may be shallow. They may be charming. They may be witty. They may go out and hang out at bars, but they're going out and hanging out at the bars because they want to meet someone so they can flirt with them, so they can drug them, so they can then take them home and rape them. And they're not going to feel bad. I'm doing it because I want to. So when we are assessing these patients, they're not going to always be honest. They're not necessarily going to want to care. They're not going to enter treatment unless it's court ordered because it does not bother them. We may see them get admitted for anxiety or depression. We may see court ordered. I'm coming to treatment because I want to avoid some type of legal or occupational difficulties. We may see the population due to physical consequences because they have that high-risk behavior. So we may see them because of high-risk behaviors, because of an acute injury, because of substance use. And again, they may be defensive. They may not be telling the truth. We do definitely have to do that self-assessment, monitoring our behaviors and responses. It's hard to communicate with this patient because they're going to try to manipulate you. This is very much that no means no. Can I make a phone call? No, phone time is at 4 o'clock. You do not discuss it because they will manipulate the situation. We have a few slides on this patient. Our outcomes, what we want to see, if they're not coping, we want to see them coping. If they were aggressive, we want to see self-restraint. But again, they're going to be difficult. Safety on the unit is especially a priority. Monitoring them, they're just going to steal from other patients, that risk behavior, food, clothes, all that stuff. And when they're stealing from other patients, it just creates turmoil on the unit and a dangerous situation. So again, what are we doing as nurses? Planning, boundaries, limits. We have to give them realistic choices. We have to keep safe. We have to use therapeutic communication to at the simplest, but again, no is a full sentence. For pharmacology, there really are no approved medications. We do have off-label. So mood stabilizing medications can help with the symptoms. Patients are really going to stick to long-term relationships, so they may not see an advanced practice prescriber if at all, ever, or at all. So again, antisocial personality, high-risk behaviors, they are serial killers. They are not someone who does not want to go to the party. That would be your schizoid. Your schizoid is the person who has no friends, who wants to stay by themselves, not antisocial. Borderline personality. This is honestly the patient we are going to see most frequently in the psychiatric setting, especially acute care. Why? Because having traits of borderline personality disorder is a huge risk factor for suicide. Huge risk factor. They're self-destructive. They are labile. They are impulsive. You cannot leave sharp things around them because they will immediately just take it and try to kill themselves. A major feature in this disorder is that marked stability, instability in emotion. They cannot control their emotions. They're impulsive. Their identity and self-image is distorted, that unstable mood, unstable relationships. It is the most well-known and most dramatic of the personality disorders. Severe impairment in functioning in all. Where we might not see the narcissist in treatment, we will see the borderline. Trying to think if I'm forgetting. Emotional lability, and I don't know if you've talked about it in clinical, it's going from one mood to another, to another, to another. Their moods are all over the place. It's a nice fancy way, emotional lability, to say mood swings. They very much self-destructive. Cutting, self-harm, promiscuous behavior, substance abuse. And honestly, we see unintentional suicide in this population. It is often very much, I'm going to cut myself and have this suicide attempt, but I'm going to call someone. And then eventually it's like the boy who cried wolf. They take one too many pills on accident. Chronic suicidal ideation is super common. And it is very much influences the likelihood of these accidental deaths. Suicide threats. I always kind of think of this one, and we'll talk about that splitting. The inability to view both positive and negative aspects of others as a whole. I tend to think as that borderline, I love you, I hate you, don't leave me, but if you leave me, I'm going to kill myself. That you're good or you're bad. In splitting, there is no in between. We tend to see splitting play out on the unit in a individual's borderline is going to be like talking to one of the nurses and be like, "Oh my gosh, you're the best nurse ever. All of the other nurses hate me." And they will seriously like turn the nurses against each other. Um, but then if you're the nurse they love, if you do something that they don't like, immediately they hate you. There is no going back. There isn't an in between. Um, if you try, there's a very big in that unstable relationships, that fear of abandonment, and that's where that suicidal threats come in. Um, Borderline, like I said, we can't diagnose until we're 18, and honestly, a psychiatrist once said because we would diagnose almost every teenage girl with borderline. Um, this is very much if you break up with me, I will kill myself because that fear of abandonment is so big. Prevalence 1.6, however, 10% suicide risk. 85% of them have another mental illness. There's something else going on. Major depressive disorder, substance abuse, anxiety are big. Men with borderline tend to have substance use and antisocial all at once. We do tend to see a good risk if we're talking about genetic. It's 5 times more common in those who have a first-degree relative with the same disorder compared to the general population. We do see serotonin come into play. We do have a child psychologist who believed that this disorder results from separation, individuation between the mother and the child. As the infant progresses from complete self-absorption, they can't always separate the self from the mother physically and psychologically. I would not. It's a very psyche type response, but it is one of them. We do see high rates of abuse, high rates of trauma in these patients too. If we are assessing this patient's structured interview, MPI is a specific questionnaire that we can do. You answer these questions. It tells you kind of which validity, reliability, like which personality disorder you may have. Self-assessment. It is very, very hard to work with these patients. I've worked with adults, I've worked with peds, I've worked in addiction, and honestly, working with like teenage patients, I had a lot of 16, 17-year-olds who had a lot of the traits of borderline. It is exhausting. Having these patients in addiction treatment, having these patients on an acute psych unit, like they will ruin the unit. They're so unstable, and then they get all of your other patients unstable. So we very much have to, especially if they're doing that splitting, like compartmentalize and work through it. We have a lot of nursing diagnoses. Self-mutilation, risk for suicide, risk for violence are our big ones. Again, these patients are a high risk for suicide. We definitely are going to be searching these patients, doing that suicide assessment. Do not leave anything potentially sharp or dangerous around them because that impulsivity in suicide is what gets an individual's borderline. Nursing outcomes is going to depend. We got the therapeutic relationship. They do tend to be very manipulative, and you cannot buy into the manipulation. Consistent limits, consistent boundaries, very straightforward. Talk about their goals. We have to keep that teamwork, safety, especially with that risk of self-harm. This is very much like you don't even leave a pen sitting on the table because they would take their pen and stab themselves. If they are doing superficial self-injuries, we do have to be matter of a fact. We don't want to buy too much into it, but we don't want to necessarily like pull away. Pharmacological interventions basically depends on what's going on. There are some meds you can see used, but no specific meds. Psychotherapy is going to be the best. Though we've always talked about cognitive behavioral therapy, dialectical behavioral therapy tends to work better with an individual with borderline, and it does a lot more with like mindfulness. It's a different version of therapy, but it works well. Cluster C is our last cluster. These are anxious, they're nervous, they're fearful, they're scared. A lot of times about like how others will perceive them. And when we look at it, our first one, and again, you're going to confuse this, we have avoidant. So schizoid, antisocial, and avoidant tend to all get confused. Schizoid is our cluster A, and that is that loner. They don't have any relationships. They're the 40-year-old virgin. Antisocial, you're just going to confuse because the name is antisocial. And you're going to think they don't like other people, when in reality, they're a serial killer. Avoidant is shy. They feel inferior, so they're not going to engage with new people. They're going to have a friend. They might even have a girlfriend or a boyfriend. But it's going to be like, I've been best friends with Samantha, and we've been friends for 2 decades. And she treats me horribly, but I'm so afraid to go into a new relationship. I'm so afraid that someone else is going to be mean to me that I stay with Samantha even though she's mean to me. Who stays with like the narcissist? A lot of the people in cluster C. They're going to avoid interpersonal contact due to fear of rejection, due to fear of criticism, feeling inadequate. Found equally among men and women, 2.4% of the population. We see it as shyness and avoidance in during infanthood, and early childhood. Low self-esteem, feelings of inferiority. They're just not going to engage in new people, new situations. So what do we do for these patients? Treatment's going to be individual and group therapy. They need group therapy, no specific meds, but we can give meds for symptoms, right? If they're anxious, if they're depressed, we give an SSRI. We have to be friendly. We have to accept them. We want to teach them social skills. Design exercises to prevent failures. We want them to fail and realize that it's all going to be okay. We may need assertiveness training. This is another one where work and jobs are going to be hard because they're not going to want to interact with other people. Our next cluster C is dependent personality disorder. When we look at dependent personality disorder, these are submissive. They have a high need to be taken care of. Again, separation and abandonment comes into play. They want someone to take care of them. Again, who stays with your narcissist? Who stays with your serial killer? The dependent. They would get upset if their spouse left even just to try to go to work. They want someone to take care of them. They're going to be doing whatever their husband tells them to do because they are submissive. It is very rare to be truly dependent, 0.5%. We can sometimes see this as a result of a chronic physical illness, punishment that happened during childhood. So if we had a child who was extremely sick when they were younger and had that like helicopter parent who didn't let them do anything, then they kind of just grow up being submissive, being dependent. It could be an inherited trait. We have looked at that. Fear of separation, fear of abandonment. They're going to lack confidence in their own ability, in their own judgment. They may even manipulate others to take responsibility for finances, for raising the kids because they just don't think they can do it. If you leave them, it's going to make it worse because they just don't know what to do. They're going to be insecure about their lack of self-confidence, which then creates this cycle because they're not going to want to become more independent. And anxiety when left alone, even for tiny periods. Psychotherapy is again our treatment of choice. No specific meds. We can do anxiety meds if they're anxious. We want to talk about their stressors. We have to set limits, but we don't want them to be punished. Countertransference. We don't want to take care of them. We want them to be able to do things for themselves. And then we have to teach them assertiveness. Our last personality disorder is obsessive compulsive personality disorder, OCPD. Now, when you tell someone, oh my gosh, you're so OCD, and you mean super type A, you actually mean you're so OCPD. So this is a perfectionist. In my head, OCPD, the P stands for perfectionist. They're stubborn, they're indecisive, and they have a preoccupation with orderliness, perfectionism, control. This is one of the most prevalent personality disorders, 2 to 8% of the population. We do tend to see it more in men than in women, more often in oldest siblings. Risk factors, harsh discipline, and a first-degree relative with this disorder. We do see high rates of depression, increased suicide risks, especially if we have depression going on with this patient. Rigidity. They're not going to change. This is how it's supposed to be, and this is it. It cannot be different. Inflexible standards for themselves and other people. So they have these super high goals, this is how it's supposed to be. We cannot do it differently. And they're going to blame it on everyone else. I always joke, this is like the fight I get into with my husband about how the bathroom towels have to be folded. We have 3 bathrooms. Each bathroom has their own set of towels, and each bathroom has its own different way of how the towels have to be folded to fit in the cabinets. You have to fold the towels this way. There is no other way to do it. And I push that, and honestly, it's caused fights between my husband and I because he folds the towels wrong. They're going to rehearse over and over how they're going to do things in social situations because they're going to be so nervous. Excessive goal seeking that is self-defeating. They are going to set a goal. And sometimes I see it in nursing students. I have to get an A. Y'all, C is a degree. But they're going to keep trying to push to reach these goals, even if the goal is one they made. The goal doesn't matter. They're not going to finish projects. They're going to have like a craft closet half full of all these projects because they are going to have it perfect. And if they cannot get this project perfect, they're just going to quit. They're not going to be able to do it because it's their strict standards, no one else's. We do have to remember there is a difference between OCD, which we've talked about before, and OCPD. OCD, we have the obsessive thoughts and that repetition, that adherence to rituals. In OCD, they are aware of the unreasonable thoughts. They're aware of the unreasonable actions. So one of the examples we talked about when we talked about OCD, I'm driving down the road, I go over a bump, I have that thought, oh my gosh, I killed someone, I hit someone with my car. I'm going to get out, I'm going to walk around my car, make sure I didn't hit anyone. And I realize I should not be getting out of my car. That is OCD. In OCPD, it's that unhealthy focus on perfectionism. They think their actions are right. They feel comfortable with the self-imposed rules or systems. They don't realize that there's anything wrong with what they are doing. They think this is how it's supposed to be. They are affectionate. They love their family. They love their friends. However, leisure activities, friendships are not going to be priority because they're going to focus on their devotion to work and productivity. When we look at the guidelines, we have to guard against power struggles. They're not going to do well with unexpected changes. They may seek help, but they also may not. It does say they tend to seek help because they realize they're suffering, but they're seeking help for anxiety, for depression. They're not always going to go because of the rigidity of standards. Treatment is going to be long and complicated. It is not going to be easy. They will do well in group and therapy. We do have some specific meds. Fluoxetine is Prozac. That can help with the obsessions, anxiety, but again, they're going to need therapy. Like this is a person, if you go on vacation with them, they're going to have a schedule. And it's like, this is what we're going to do every minute of vacation. And if the schedule goes wrong, they lose their mind. Y'all, that's it for personality disorders. I know that's still a lot. If y'all have questions, let me know. Otherwise, I will see y'all in class.